Have you ever thought about um, a condition where your blood pressure could be really different in each arm?
It sounds quite specific, doesn't it?
Yeah, like something from a medical drama. But it's actually a key sign we're exploring today in our deep dive on Takayasu's arteritis.
Exactly. We're going through the MSRA revision notes, trying to pull out the absolute essentials for you.
That's the plan. Cut through the noise, get the high-yield stuff you need for exams, or just for understanding this rare condition efficiently.
So, Takayasu's arteritis, let's define it simply. It's a rare chronic autoimmune condition.
Autoimmune, okay. So the body's attacking itself.
Pretty much, it targets the large arteries. Think the aorta, the big one, and its major branches.
And what does that attack do?
Well, it causes inflammation in the artery walls. This can lead to narrowing, which we call stenosis,
Stenosis, right?
or even weakening and bulging, which are aneurysms.
Okay, so inflammation leading to either blockages or weak spots.
Got it.
Now, who gets this? You said it's rare.
It is rare overall, but it's definitely more common in certain groups, primarily young adults, especially women.
Young women. Anything else?
Yes, there's a notable prevalence in individuals of Asian descent. And just a bit of history. It was first described back in 1908 by Dr. Mikito Takayasu. He noticed specific eye changes linked to it.
Interesting. So young Asian females are a key demographic to remember. What about the cause? Is it known?
The exact trigger, still unknown, unfortunately. That's important to remember. But the strong suspicion is an autoimmune origin.
So, like we said, the immune system getting confused.
Exactly. There might be genetic factors, maybe environmental triggers playing a role, but the core mechanism is believed to be autoimmune.
Okay. And how does that autoimmune attack actually damage the arteries? What's the pathophysiology?
So it starts with chronic inflammation, persistent inflammation in the artery wall.
Right.
This causes the inner lining, the intima, to thicken. That's intimal hyperplasia.
Yeah.
And then you get scarring, fibrosis,
So thickening and scarring.
which ultimately leads to that narrowing, the stenosis, or sometimes complete blockage, occlusion,
And the result of that blockage.
reduced blood flow,
Hmm.
less blood getting to the organs and tissues downstream, which causes all sorts of problems depending on which artery is affected. Think of it like, pipes getting clogged up.
Clogged pipes.
Yeah.
Yeah, that makes sense. So if a clinician suspects Takayasu's, what else needs to be on their radar? What conditions look similar?
Good question. Differential diagnosis is key because it's rare. You need to think about other types of vasculitis first.
Like what?
Giant cell arteritis is a big one, though that typically affects older people. Behçet's disease is another possibility.
Okay, other vasculitides. Anything else?
Yeah, you also need to consider non-inflammatory things, like atherosclerosis, hardening of the arteries, though the pattern is different. Even some infections or congenital vascular issues.
So the age and the pattern of large artery involvement help differentiate.
Absolutely. Takayasu's hitting younger people and focusing on the aorta and its main branches is pretty characteristic.
Right. We mentioned the demographics rare overall, more common in Asia, especially Japan. Peak age.
Usually teens and early 20s. So think 15 to 20 years old is often the peak incidence. And that female predominance is quite strong.
Okay, 15, 20, predominantly female, often Asian descent. Let's talk symptoms. What might someone actually experience? How does it present?
It can be quite varied, which makes it tricky. Often there's an early phase with just general systemic symptoms.
Like feeling unwell?
Exactly. Fatigue, maybe a low-grade fever, losing weight without trying, perhaps some joint pain. Quite nonspecific stuff initially.
Okay, so vague symptoms first. Then what?
Then, as the arteries get narrower, you start seeing symptoms related to reduced blood flow, to vascular stuff.
Such as?
Claudication is a big one. That's pain in the arms or legs that comes on with exercise and goes away with rest.
Because the muscles aren't getting enough blood when they work harder.
Precisely. You might also find weak pulses or even absent pulses in some limbs. High blood pressure is common too.
And other things. Neurological, maybe.
Yes. Dizziness, fainting spells, syncope or visual disturbances can happen if blood flow to the brain or eyes is affected. Chest pain or shortness of breath if the heart or lung arteries are involved.
Wow, okay. So it really depends on which pipes are getting clogged. Are there any really specific clues, sort of red flags for Takayasu's?
Definitely. That unequal blood pressure is a classic. A difference of more than 10 mmHg systolic between the arms. You really need to remember that one.
More than 10 mmHg difference. Got it.
Also, hearing a bruit, that whooshing sound with the stethoscope over an artery like the carotid or subclavian, Tenderness over the carotid artery can also occur.
Okay, bruits and tenderness.
And limb claudication in a young person should always make you think. Plus, sometimes aortic regurgitation, a leaky aortic valve, which happens in maybe 20% of cases.
That blood pressure difference seems like a really key physical sign. You mentioned stages earlier, systemic and occlusive. Can you quickly recap that?
Sure. The systemic stage is really about that initial general inflammation, fever, fatigue, joint pain, malaise, just feeling generally unwell.
The vague phase.
Right. Then the occlusive stage is when the artery narrowing causes specific problems because blood flow is restricted.
So that's when you get the claudication, the neurological symptoms, maybe kidney issues if the renal arteries are hit.
Exactly. Jaw claudication pain when chewing arm or leg claudication, visual problems, strokes, chest pain, depending entirely on the location of the stenosis.
Makes sense. And on physical exam, besides the blood pressure difference, what else might be found?
Well, obviously, the weak or absent pulses or pulse differences between limbs, those arterial bruits we talked about, hypertension is found in about half of patients.
50%. Okay.
Sometimes an eye exam, ophthalmoscopy can show vascular changes, and then non-specific things like maybe anemia or muscle wasting if it's been going on a while.
So a whole constellation of potential findings. Are there formal diagnostic criteria?
Yes, the American College of Rheumatology has criteria, often simplified into major and minor ones for quick recall. A key major one is symptom duration over a month.
Okay, symptoms lasting a while.
Other major criteria include limb claudication, decreased peripheral pulses, that BP difference 10 mmHg, and subclavian or aortic bruits.
And minor ones.
Things like elevated ESR, that inflammation marker pain over the carotid artery, carnodenia, hypertension, and maybe aortic regurgitation. You typically need a combination to meet the criteria.
Right. Helps standardize things.
Yeah.
So quick summary definition again.
Okay. Chronic, progressive, inflammatory disease hitting the aorta and its main branches in young people, especially Asian females, causing narrowing, blockage, or aneurysms.
Perfect. Now, investigations. How is it actually diagnosed or confirmed?
Imaging is absolutely central. You need to see the arteries.
What kind of imaging?
Angiography is the gold standard, really. Visualizing the vessel lumen. This can be conventional angiography, but more often now it's CTA, CT angiography, or MRA, MR angiography.
So CT or MRI scans focused on the blood vessels.
Exactly. They show the extent of the stenosis, occlusions, aneurysms, and even inflammation in the vessel wall itself if you use contrast. Doppler ultrasound can be useful for screening or follow-up.
Okay. Any role for PET scans?
Yes, P scans can be helpful, particularly for assessing active inflammation. It looks for increased glucose uptake in the inflamed vessel walls.
And blood tests. You mentioned ESR.
Yeah, blood tests are supportive, but not diagnostic on their own. There's no specific antibody tests like in some other autoimmune diseases.
So no single blood test says, yes, it's Takayasu's.
Correct. You might see normocytic anemia on the full blood count. The ESR is often elevated, especially early on. Maybe some other non-specific markers of inflammation like increased fibrinogen or globulins, but crucially, nothing specific for diagnosis or staging.
What about a biopsy? Taking a piece of the artery?
It can be diagnostic, showing the characteristic inflammation, especially early on. But it's invasive, obviously, and often the diagnosis is clear from imaging and clinical picture, so it's not always necessary, especially later in the disease.
Right. Imaging usually tells the story. The notes mention classifying it based on angiography.
Yes, there's a classification, types I to V, based purely on where the disease is located anatomically along the aorta and its branches.
Like type I is just the arch branches, type V is everything.
Something like that. It describes involvement of the ascending aorta, arch, descending thoracic, abdominal aorta, and renal arteries. It just helps characterize the extent and pattern. Not super crucial for initial diagnosis, but useful for management and prognosis.
Gotcha. Okay, let's talk management. What's the treatment approach, thinking UK context?
The absolute mainstay is immunosuppression. You have to control that inflammation.
Ow.
Corticosteroids, like high-dose prednisolone initially, are first line to get the inflammation under control quickly, then usually tapered down.
Steroids first. What else?
Often, other immunosuppressants are added, sometimes called steroid-sparing agents, like methotrexate or azathioprine. Cyclophosphamide might be used for very severe cases.
And if those don't work?
Then you move on to biologic drugs, things like TNF inhibitors, infliximab or adalimumab, or sometimes others like tocilizumab or rituximab for resistant disease.
Okay, a range of immunosuppressants. Anything else?
Yes, antiplatelet therapy, like low-dose aspirin, is often recommended to reduce the risk of clots forming in the narrowed arteries. potentially preventing strokes or heart attacks.
Makes sense. And blood pressure.
Absolutely critical. Aggressive blood pressure control is vital because hypertension is common and worsens outcomes.
Right. What about fixing the narrowed arteries themselves?
Sometimes necessary if there's critical stenosis causing significant symptoms. Endovascular procedures like balloon angioplasty or stenting can be done for shorter, narrowed segments.
Sticking a balloon or tube in to open it up.
Yeah. For longer segments or complete blockages, surgical bypass grafting might be needed.
Oh, there's a catch, right, with the timing.
A very important one. These procedures, angioplasty, stenting, surgery, should ideally be avoided during the active inflammatory phase of the disease.
Why is that?
Because inflammation makes the vessels fragile, and intervening can lead to complications like restenosis, re-narrowing, or aneurysm formation at the site. You want to cool the inflammation down first with medication.
Okay, immunosuppression first, then consider procedures if needed once things are stable. And regular monitoring is key.
Essential. Regular clinical review, checking blood pressure, monitoring inflammatory markers, and often repeat imaging to assess disease activity and response to treatment.
Okay. What about the long-term outlook? What's the prognosis generally like?
It's variable. About 20% might have a self-limiting course, believe it or not.
Oh, really? It just burns out.
Sometimes, yes. But for most, it's chronic. Mortality rates used to be higher, but with modern treatment, survival is generally good, especially if there aren't major complications like stroke or severe heart involvement early on.
So, treatable, manageable for many.
Yes, long-term remission is achievable. Some studies show really high rates, like over 90%, achieving remission eventually with treatment.
What makes for a better prognosis?
Factors like having a low ESR at presentation, responding well to initial steroid treatment, and generally being in a stable condition seem to predict a better outcome.
Good to know. Finally, what are the main complications we need to be aware of?
The big ones relate to that reduced blood flow or vessel damage. Loss of vision is a serious one. Persistent hypertension, which itself causes problems.
Joke.
Definitely stroke. Aortic regurgitation leading to heart failure. And myocardial infarction, heart attack, if the coronary arteries get involved, although that's less common.
Okay, quite a list of serious potential issues.
Yeah.
Needs careful watching.
Absolutely. That's why the monitoring and management are so important.
Right. So let's do a super quick takeaway summary. Takayasu's arteritis. What are the absolute key points to file away?
Okay, think. Young females, often Asian descent, inflammation of large arteries, especially the aorta and its branches, unequal blood pressure between arms, that 10 mmHg difference, bruits, claudication.
And diagnosis.
Imaging is crucial, CTA or MRA. Treatment is immunosuppression, mainly steroids first, then maybe other agents or biologics. Control blood pressure. Avoid procedures during active inflammation.
Perfect. Concise summary. That's really helpful.
Hope so. It's about nailing those key features.
Definitely. And if you want to dive deeper, do more revision, or test yourself with practice questions on Takayasu's and other MSRA topics, make sure you head over to passmsra.com.
And also check out freemsra.com for more resources. They're both great for getting prepped.
Absolutely. Good luck with all your studies.
Yeah. Best of luck. Understanding these conditions piece by piece really builds up your knowledge base.